Hello and welcome. Good evening to the Atmarker series of Prof Talks with me, Jonathan Snicker, and Professor Andrew Shaw. Just waiting for everyone else to join. We've got a good crowd coming on this evening. Excellent. Andrew, would you mind saying a few words of introduction, please?
Evening, Jonathan. Evening, everyone. Nice to see the numbers rising. So yes, I'm Andrew Shaw. I'm Associate Prof at the University of Exeter, and I'm also founder and director of Atmarker. Why be an academic entrepreneur is an interesting question. And the answer's got to be so that we can get a good quality test out to large numbers of people.
Thank you, Andrew. While we're waiting, a brief survey will appear on your screen just as everyone else joins. If you kindly fill that out, please. Great, thank you. A little bit of housekeeping. This session is being recorded and will be available on YouTube shortly. There are a number of useful podcasts and webinars, including talks and conversations between Andrew and doctors like Dr. Benita Kane and Dr. Ben Sinclair, who both specialize in treating non-COVID. Secondly, this webinar is about the science behind the COVID antibody spectrum test and some of the treatments clinicians are using. It does not constitute medical advice. It's very important to emphasize that. Please speak to your clinician about the Atmarker test or provide a link that will appear at the end of this session. In this session, the primary focus will be on children who have long COVID and people who have an hyperimmune response. We're here to help you, and part of the way we think we can help you is obviously through this COVID antibody test, and also to bring this community together and also try and answer your questions. Please use the Q&A chat, not the chat, the Q&A to ask your questions. All right, so we've got just under 30 minutes, so I'll kick off. Andrew, for the benefit of people who are new to the Atmarker test, can you explain briefly how it works, please?
Yeah, so the antibody spectrum test looks at the host response to 14 variants of SARS-CoV-2. The idea here is that if you've had a specific infection from a particular variant and that's hanging around, we should see whether your response to that is good. Or indeed, if you've invented your own variant during an infection, we might have some idea about whether you've got a good spectrum response or not. And our key differentiator is also we're looking at antibody quality. Why is that important? Because the antibodies are going to work all around your body, and your body's not the same everywhere. So if you look at different parts of your body, just different pHs, how acidic your body is in various places. Very acidic in your stomach, which you probably know about from stomach acid reflux problems. Your saliva is a bit more acidic, and the rest of your blood is at a less acidic state. And so do your antibodies work in all those conditions, especially on those? So we get to look at quite the idea of your response and how good it's been across what might be a number of 14 variants.
Great. Thank you, Andrew. So we've got the poll result in. The question was, have you taken an Atmarker COVID antibody spectrum test? And 43% of the participants already have. 57% have not. All right, moving on, we're going to look at the hyperimmune response first. And one of the questions we have is the autoimmune response or hyperimmune response downstream of pathogen resistance?
Gosh. So without me turning this into a lecture, although that would be fun, let me just explain what the hyperimmune response is. And the background here is that we are looking at what happens to the response of the patient after the acute infection has gone. So you've got rid of all the runny nose and hopefully your taste has come back and all such things. But if the body has not cleared the virus from your from all around your body, all over your body, in your lungs, in your digestive tract, in your heart, then there's a problem, and that might cause all sorts of symptoms. The other question is whether, and this is the autoimmunity question, whether for some reason or other the body has decided to attack itself because of your response to the infection. So that could be autoimmunity, and certainly in our test we call that scientifically hyperimmunity. So what we're seeing for long COVID patients is this. So across the bottom here, this is a good responder. See, they got good antibody levels in the bottom corner here, and that are also high quality antibodies. 60% or more are high quality antibodies, and that's what you want to look like. That means you've made good antibodies at a good concentration across the full spectrum. If you look at this long COVID patient here, this is a poor spectrum response, both very low concentrations of antibodies, and none of them are very good quality. Another long COVID patient here, some good quality antibodies, often from the vaccine response to Alpha, Delta, and Wuhan. Those are good quality antibodies, but this is the interesting bit. They didn't make good quality antibodies to the rest of the spectrum. So about 2/3 of long COVID patients, 65% of long COVID patients look like this, but about 10% of long COVID patients, which is the subject of this evening's Prof talk, look like this. And this is a patient who's published their antibody spectrum result on Reddit. And this is an enormous concentration of antibodies, something like 20 times that that you get from a vaccine response. And it has very high concentration, and it makes these numbers, which are also very good, but it makes these numbers here look rather small. And all of the antibodies are high quality. So if you look at the quality of these antibodies, there's nothing wrong with them. But why are they there in such high concentrations? And more worryingly, they don't drop. And so that means something has switched your body on. And I think actually the accelerator is to the floor here. This is as fast as your immune system can make antibodies. I think I've seen one up to 200 milligrams per liter, but this is pretty much there. And the theory is that's a hyperimmune response. The theory is that in the process of getting rid of an infection, or indeed responding to the vaccine, you've accidentally started attacking part of your own body, possibly a heart cell, possibly a kidney cell. And so because the kidney cell is there all the time, you have a stimulus immune system all the time, and so your immune system is on flat out. And that leads to general fatigue, that leads to all sorts of problems that are part of the subset of this 10% of patients that get that have long COVID. So now this is a very different person. If you're interested in one of these trials that's happened in America, for example, antibody trials, it's good if you are one of these people, because the antibody should fill in the gaps, and that's what we're trying to do over here with sipavibart. Should you be taking any antibodies at all if this is this high, if these antibodies are this high? Indeed, could it be bad for you? That's an interesting question. I think you should know before entering into any therapy whether you're one of these hyperimmune responders.
Andrew, if I may interrupt, we've had a question which I think is quite important, a point of clarification, really. How would you describe a universal responder? What's the comparison point?
Okay, so here they've got good quality antibodies, and the level here at 8 milligrams per liter in this patient is similar across all variants. Here they are all the way up to KP3, and good concentration of antibodies, about the median vaccine response. And the quality of these antibodies are what is normal. This is what we normally produce for an infection and with complete recovery. So this is an example of somebody actually in the lab that works with us at the moment that has a good universal response across all the variants, lots of good antibodies, all high quality. So that's the universal responder.
Thank you. And there's a follow-up question, which is related to somewhat controversial subject of vaccine injury. And I know that's difficult to quantify and characterize in the scientific literature. Is there any value to this test in respect of that? Can the test discern that, or is that not possible in the context of your scientific understanding?
Okay, so very contentious question. The mechanism, I think, for autoimmunity is could be the messenger RNA vaccine escaping from your arm into, let's say, your heart. And there have been reports of people growing spike proteins in heart cells. In the process of attacking the spike protein growing on the heart cell, they've also then worked out how to attack the rest of the heart cell, and so they end up with a hyperimmune response to heart proteins as well as the spike protein. Could this be a signature for vaccine injury? Possibly. And I hesitated there because I don't know that it would be easy to prove. But the mechanism, the scientific mechanism I've just proposed, certainly is one of them. And the movement of the message from the vaccine around the body has been shown. So yes, it could be.
Yes. And it's clear in what you're saying that regardless of that debate, it actually appears to be very, very important to know, for the clinician to know whether the patient has a hyperimmune response or not, because that really should guide treatment pathways, is the implication.
So I think our classification tells the clinician, the doctors, that there are 3 types of long COVID patients: the immunocompromised with bad antibody spectra, the hyperimmune patients, and then about 25% of patients just look like they're universal responders. They have no obvious characteristics from the spectrum. If you start treating somebody like this, I don't think, for example, the other tests available pick up this hyperimmunity in the way that we do, because they give answers in numbers that are unique to the test, arbitrary units, milli-arbitrary units, milli-AU, for example. And is 2,500 milli-AU equal to 140 milligrams per litre? We don't know. But I do know from our test result that this is a big number and is as big as it gets in all antibody production we've seen. So it's quite important for the clinician to make sure they've chosen the right test and interpreted that test properly.
All right, well, I'll stop interrupting you for now. Have you got some further information on this?
So the other characteristic of hyperimmunity is that you can make a test some days later. Here's 100 days later, and you might have thought this was maybe an accidental stimulus, but at 100 days later on there, it's hardly changing. You'd expect it at least to have halved, but this suggests that this patient here is continuing to make antibodies, continuing to suffer from the autoimmune response. And autoimmune diseases also can attack any parts of the body: GI tract, the blood themselves, the brain, the thyroid. And I'm struck by how well symptoms for autoimmune diseases overlap with the symptoms that are presented in long COVID patients. Maybe a hyperimmune patient has a preponderance of one symptom over another. Maybe that's also a symptomatic diagnostic that would be useful. And the reason that it could be autoimmune then points to this rheumatology specialism in medicine. And they've worked on this, for example, in rheumatoid arthritis, which is an autoimmune disease, for example. Usually the way is management, and especially in children, that means potentially a lifetime management process, potentially with drugs supporting them. And often children grow through remission and flare-ups, and management of their autoimmune disease becomes part of their life. One of our test candidates recently asked whether, if they were taking this drug rapamycin, whether they should have the test. And it is an immune system suppression drug. And I don't think that means the test is a good idea. If they're already on this drug, then I think their antibody spectrum could be significantly reduced. But it does mean that you could take this drug and get the antibody levels under control. And I think if you are hyperimmune and your doctor can make a clinical assessment of you, then this is a potential route forward and should certainly be considered. Not very expensive. It is going to be a long-term process, but it could reduce the antibody levels. If the antibodies are attacking your heart, then you're going to get much better POTS, for example, that when you stand up, your heart rate doesn't go mad. So there's an interesting route for an immediate potential treatment for this. And I can't help but note that as a scientist, if I could change the antibody levels, get the antibody levels down, maybe if I gave you a vaccine like Novavax, I could change the recipe that's in your body that's making it wrong. Maybe I can do some reprogramming of your immune system to give you a different immune response and try and remove, therefore, the autoimmune response. That sounds like a scientist experimenting, and it is. And we haven't tried that anywhere yet with a clinical intervention. But it is a way potentially of getting rid of the antibodies and then seeing what we can do by way of changing the message. And that's quite an interesting idea and novel. We've tried it with the people that are immunocompromised. This is a before vaccination. This is an after vaccination. You see they've now got good quantity of antibodies. A bit low down here, we gave more, the clinicians gave other vaccinations to follow, but the quality is good. And this patient started getting better. So we can change the spectrum. And can I then change the hyperimmune spectrum by, first of all, suppressing the antibodies and then changing it? Interesting idea. But we haven't tried that yet. And
Just to interrupt for a second, we've had a question come in about scientific methodology, which I think is interesting. You can answer it briefly, please. I've heard from the patient community that your normative control data is based on a single person's sample. Is this true? And how can this be considered a good control?
No, we use a control group of 75 so-called normal patients. We've also validated the testing process in 200 pre-pandemic samples, and we've also validated a diagnostic accuracy study with 200 non-infected patients and 200 infected patients. And in the pandemic, that got us an emergency use certification. So I'm very happy that we are aligning with what the MHA require for a diagnostic tool, and the analysis that leads to this universal response is part of a cohort study with 75 so-called normal patients in it.
Yes, thank you. And I should emphasize it's the clinician who's making these decisions about treatments based on if they're using the anti-marker test and other data and symptom points. Andrew, you've moved on to looking at the result of a teenager, which brings us into children and long COVID. And we get a number of messages which are very moving from parents, about how difficult their child is finding the disease, and indeed the whole family, and how worried about losing childhood. One of the things, of course, is that children are very different because of growth hormones and everything else in terms of their responses. And obviously there are other chronic diseases like diabetes that occur in children and require management. And also there are issues around trials involving children and collection of blood and so forth. So Andrew, would you speak to that in the context of this slide, please?
So I agree. As a father of two young children, they're in the middle of growth chemistry every day. They're growing obviously immeasurably during the early years of their life, and that growth chemistry means that doing trials on children ethically is very difficult. In fact, there are very few clinical trials performed on children for that reason. We don't know what chemistry is going on in the growth process and how the drugs interact with those. Consequently, I also think the same growth chemistry with a persistent virus is going to change, is going to be perturbed. This teenager here wasn't a teenager when the pandemic started, and they have a very poor antibody spectrum, and they have been through many clinical consultations and collected quite a large number of drugs attempting to suppress histamine production in both H1 and H2, all sorts of inhibitor drugs for clotting, and sadly here an antidepressant, not surprisingly. And this child, growing teenager, now has lived through key developmental years, not at school, not interacting with his peers, but also now growing up doing the growth chemistry with this curious persistent virus in their body. I think we don't know what is going to happen. I know some doctors are specializing in the treatment of children. Would I be happy if this were my child to give them a vaccine intervention or indeed a monoclonal antibody intervention? I think yes. I think the balance in my mind as a scientist is worth the risk, and I would hope that under the right clinical supervision that would be a reasonable intervention.
Just to interrupt for a second here, Andrew, please, if you've joined a little later on, use the Q&A and not the chat to ask your questions. I can see some people are trying to ask questions in different ways. Sorry, please continue.
So we have heard from a hyperimmune patient here who for a long time was struggling with people not believing that they had long COVID, not believing there was anything wrong. And our results quickly produced a patient testimony that was ideal from their point of view. They suddenly realized there was a problem that put them in a very different mindset. They were able to work out life coping strategies, ways to minimize the effect of the autoimmune response, and then moved from a lifestyle that was in hospital monthly to not having been in hospital for quite a while now. So I think hyperimmunity is manageable. I think there are some drug options to make that better. I think this patient is also taking some antihistamines. So for 10% of this long COVID community, that we classify now as hyperimmune. I think there are treatments available with the right doctors almost immediately that can improve your lifestyle quality. And I think for children as well, that symptomology has been used, and the immunosuppressants are used in children. So there is precedent in the rheumatology specialism for treating those. One of the things we're about to launch is, at the minute, if you get an antibody test from Atomarca sent through the post, you get this finger prick test. And that's good for pediatric sampling, although I still think if my little daughter was unwell, there's a burden to taking some blood from the finger. And I think that may be still a bit of a challenge, certainly a barrier. The new device here is something that sits on your arm. It's a Tasso device. It's FDA approved, which we're seeking now to test. And that sits on your arm and sucks the blood through your skin, and it feels much, much less difficult. There's no hole, and the blood sample is as good as it is out of your finger, or indeed out of your vein. So I'm hoping now that for pediatric sampling, and Tasso have been working hard on pediatric sampling, this is yet another reason why we might begin to understand better how pediatric immunology, child growth chemistry could be better understood.
Right, Andrew, I'm going to do a university challenge on you now, because we've got questions and comments coming thick and fast. So I'm going to ask you a series of questions, and if you can give very quick and precise answers, be most grateful. So here's the first. Might the hyperimmune response be the body reacting to reactivating viruses such as Lyme?
So the spike protein antibodies that we're measuring are specific to that spike protein. If accidentally the spike protein looks like a Lyme protein, then yes, that could be it. But if the idea of having an antibody is it's specific to the pathogen, and you should make, and indeed your body makes, good antibodies against those targets. And so most of them should be targeted against that. If you miss the target accidentally, then yes, it could be resurgent Lyme, it could be EBV. I don't know what proportion of those are that category.
Great. Thank you. How does antibody quality relate to treatment decision? Also, are these IgG antibody quality or total antibody?
These are IgG antibody quality. We're about to publish something new about IgG1 and IgG4, which are subtypes of those that point to various other mechanisms. So it's specifically those, not IgM or IgA. And the quality is pointing towards how long the antibody sticks on the virus or the protein. And it needs to stick for long enough to get mopped up by the body's immune system. If it drops off too quickly, the body then doesn't clear it. And that minimum target time seems to be, in healthy patients recovering, seems to be around 2 hours or so. And the quality measure at around 50% in the way that we measure it is the one that's reporting that stability.
Has the Atomarca test been tested by other scientists in controlled trials? Has it been peer reviewed?
So 4 publications are now at the journals waiting for peer review. They've been, 3 of them are out on the preprint servers. And the trial, the test have been used by clinicians in the private sector, but not in other scientific studies. We are moving towards participating in clinical trials ahead of interventions with antibodies, for example. And I'm trying to get ourselves associated quickly with a study that's centered at a university.
Thank you. In a hyperimmune patient, could any virus, e.g. a cold, reignite a disproportionate immune response, keeping antibody levels too high?
So in principle, a viral infection would trigger your acute phase response, and that would make you sick and then make you better. That could release in that process reservoir virus, persistent COVID virus. If in doing that, you then get a flare-up after an infection, and hyperimmune patients report flare-ups, report bad days, bad weeks, especially after like new COVID infections, for example. So yeah, I think it's possible that the immune response to an infection or of any type could trigger a flare-up, and so trigger the hyperimmune response.
Thank you. Comment here. I wanted to mention that rapamycin used at low dose, 5 milligrams once a week, which is what people are using for long COVID, acts as an immunomodulator, not an immunosuppressant. At this dose, it supports T cell exhaustion and improves autophagy and mitophagy. Excuse my pronunciation. Any comment on that, Andrew?
Yes, at low concentrations, I agree, it's a modulator rather than a suppressor. If at higher concentrations, it does reduce antibody production. So it depends on what the clinician is prescribing and what the clinical effect is and what the symptom effect is. I can't, I'm a scientist, so I can't say exactly what the right dose is, but if clinicians are converging on a lower number to reduce antibody levels with symptom improvement, then that's why that's there. And that would explain the chemistry behind the antibody test.
I have a friend based in the US. Do you have a partner clinic in the US, and how do they register their interest in joining a shipping batch?
We are bringing over the first batch of samples from the US as we speak. I think there are 60 samples scheduled to come out shortly. We then now have a partner in Alabama, which will help do the distribution. So yes, I think if you contact us, we can try and associate you with either this incoming wave or the next wave. We will be looking for clinical partners in the US, and I'm really excited about trying to get close to a Sapavibart trial at the University of Southern Florida. So we might even get the clinical validation I'm looking for.
Great comments and questions coming in here. Thank you so much. We're not going to be able to answer all of them, but I'll allow it to run over a few minutes so we can get a few more done, if that's okay with you, Andrew.
Yep, keep them coming.
So we're about to put another survey up. Steve, if you would kindly do that. After hearing our webinar today, would you consider purchasing an aftermarket COVID antibody spectrum test? And so far we've got around 65% saying yes, 29% saying, 30% saying maybe, and the rest saying no. Here's a question from David Martin. People recover from long COVID appears with a wide range of timing. Will medical drugs only speed up the process of recovery, or are they necessary in some cases to enable recovery?
Recovery is unknown. I often say that a long COVID patient may have been have long COVID now for 5 years. It's a 5-year journey in, and it could be a 5-year journey to recover. We have seen Lazarus recoveries where people have had medication and felt better almost overnight. Things like gut problems and brain fog have been specifically quick to recover. I think there's a risk now that 5 years in, if there's persistent inflammation, there may be damage, especially as we mentioned in children where growth is happening around damage. I think there's a risk around that being a slower recovery. So I expect to see, even if we eliminate any persistent virus or spike proteins, the recovery trajectory looks difficult. We are working on a recovery marker, which is IgG4, which is one of these food intolerance antibodies, and we know that it's being raised to spike protein. And I'm hoping that if we remove it, that IgG4 will then go down, but it still doesn't follow that the symptoms recover quickly. So I think the recovery profile is difficult, even if we fix the antibody spectrum.
Okay, so quite a technical question coming in here. In your previous webinar with Dr. Sinclair, you mentioned that you have observed that IgG4 is elevated in long COVID patients. Have you observed this specifically in hyperimmune profiles? And is there a test for this that is commercially available?
So yes, that's what I've just alluded to, that the IgG4 and the IgE tests we're now experimenting with in the lab. I want to calibrate them accurately and then need to validate them. We've tested it on small numbers of patients, and IgG4 and IgE are raised in long COVID patients, not specifically in hyperimmune patients. It is elevated in hyperimmune patients. It should be elevated in patients with persistent virus. I would expect it to go down in those that have got persistent virus if we clear it, but not change in those patients that are hyperimmune. I'm hypothesizing here, but I think they feel like reasonable bits of science.
Great, thanks, Andrew. I'll take a couple more questions. Just in the meantime, The test is available through a number of clinical partners, and we're hoping to get more, planning to get more worldwide. Someone mentioned Canada. We've obviously mentioned the United States. We're talking to people in Germany and other countries. One of our clinical partners, to give you an example, idea of the price, test plus interpretation is £325 with one clinical partner. You can find out more information on the artmarker.com website. Okay, just a couple more questions to end. Will this test be available on the NHS?
I think that the journey to the NHS requires an intervention study that shows that the test followed by intervention then works. It could be supplied to the NHS now. It has a UKCA mark and it is registered with the MHRA. If an NHS hospital decided it was the right test to be using, then they could request it now. My feeling is that they're going to want to see an interventional study, and that's exactly where I want to be. If we could be associated with the South Florida study, for example, then and validate it in a cohort, then it would become, I think, the standard for the selection of a test and treat program. That's where I want to get to. It should be available in the NHS because I think it's useful.
Yes, and there's a related question here. And this speaks to some of the structural issues we've been discussing. And there are elements of kind of advocacy here that we need to think about, because obviously, by definition, a community that is unwell, it's difficult to find the energy to advocate for drugs, appropriate drugs to come into this country where they're available elsewhere. So here's a related question. Would you expect that most NHS rheumatologists would recognize the significance of the antibody test results in a hyperimmune long COVID patient?
So I think a rheumatologist would look at our result and look at the antibody concentration and know that that's high. And they might then run other tests to triangulate. Say, for example, if they are used to using the Roche platform and they get an antibody level of 100,000 milli-arbitrary units, they might then say, well, that correlates too. There's another test called an anti-nuclear antibody test, which is another marker of autoimmunity. It's quite prevalent in people as they get older. So I would have said that an indicator from our test of hyperimmunity would then trigger a series of other investigations in a rheumatologist, and that would then lead to an intervention.
Great. Thank you, Andrew. There's more questions coming in. We'll try and answer some of them on the FAQs on the website. And we've got a future webinar, which I believe, Andrew, is about the planned Cevavibart trial. Can you mention that briefly?
Yes, we're talking to AstraZeneca. I've got a meeting with them on Monday with the view to, first of all, shipping Cevavibart into the UK so that the private clinics with which we are partnering can use it if they think it's clinically justified. I'm talking to the trials I mentioned in South Florida and the AstraZeneca global lead for Cevavibart with the view that we might try and get in front of that trial by way of testing. So I'm hoping that within June, some people will have had an antibody test and had an intervention, and we'll be able to see what the results look like. I know one of the people who's been tested is flying to Switzerland, sorry, to get an intervention because Cevavibart's available there. And I know the German, we've recruited a German clinic recently who is similarly now able to test and treat. I want that to be possible in the private clinics in the UK if the doctors think it's the right thing to do.
Great. Well, thank you so much, Andrew, for giving up your time and being subjected to a rather challenging series of questions, which once again shows how knowledgeable the long COVID community is about this challenging condition. As I say, the webinar will be placed on YouTube in due course. Thank you, Steve, for being in the background, helping out. Is there anything that you'd like to add before I close?
No, it's been really great. We really hope everybody's enjoyed it. Apologies if we've not managed to get to your answers. We're going to see if we can perhaps take some of these answers offline. But as Jonathan said, we're going to be putting this up on YouTube as well. But look out on the website for the 12th and the 18th. We're going to have the Prof back. He's going to be talking more, and we'll be able to answer more of your questions. So just a heads up for the 12th and the 18th.
Great. Well, thank you again, everybody, for taking the time to listen to this talk. I hope it's been helpful and look forward to joining you next time. Good evening. Bye-bye.
Bye-bye.